Hello, everyone, and welcome to another episode of the Overcoming Chronic Illness podcast. My name is Dr. Brian Rade, and I'm a naturopathic doctor, and I'm very pleased to be joined today by one of my naturopathic colleagues, Dr. Todd Maderis. Dr. Maderis joins me from the beautiful west coast of the US of A. And Dr. Maderis, if you don't mind just introducing yourself to the listeners, if you could just say a bit about who you are and how you got involved with treating complex chronic illness, that would be wonderful.
All right, great. Well, thank you for having me, and feel free to call me Todd. Um, how did I get involved with complex chronic illness? You know, Probably like a lot of our colleagues that treat the patient population we see. I started out I was always interested in environmental medicine. I've been practicing for 15 years now and had always been drawn to environmental medicine. Like a lot of physicians in our world, we see people that come in with fatigue and other, aches and pains and cognitive issues. And about a decade ago or so, I started seeing patients coming in the door with Lyme disease results and not really knowing what to do with them, and had been sick for a number of years. And I wanted to do what I could to help them. I probably fell on the list of physicians they had seen. There was and hadn't gotten better, and I wanted to do everything I could to help them. And so started treating tick-borne infections back in 2012. Went to some great conferences and became a member of the International Lyme and Associated Disease Society. And soon after, about a year later, I was at an ILADS conference, and there was a physician speaking about mold illness, which I thought was very peculiar because most of those conferences are related to tick-borne infections in one way or the other. And once you hear some information, I think it's hard to go back and pretend like it's not there. And the reason why he was speaking about mold at a Lyme conference was because mold can present in similar ways, cause a lot of the same immune dysregulation. And it's been a better part of the last decade. I've been treating both tick-borne infections and mold illness and other chronic infections, viral infections, etc. That's kind of what led me to this point in time. And it's always a pleasure to see patients that have myriad of symptoms and maybe have fallen through the medical cracks. And if we're able to help them, it's always a good feeling.
It's definitely very rewarding, and
Yeah.
couldn't agree more. And do you mind just sharing where you practice and what your clinic's called and
Yeah.
whatnot?
Yeah. So I'm, as you mentioned, I'm on the west coast of the United States. I'm in California, just north of San Francisco, actually just across the Golden Gate Bridge, in what's called Marin County. It's a lovely area with lots of outdoor space. And our practice is called Marin Natural Medicine Clinic, and been here for 15 years.
Fantastic. That's great. Well, I've been excited to chat with you because as I was saying before we started recording, I've been following you on Instagram, and we'll post to your in the show notes. I'll post your Instagram page after the interview is done. But just I really enjoy your content because you post a lot of really interesting topics. You're posting about more cutting edge research things, which I was saying saves me a lot of time because I try to stay abreast as best I can, but there's so much stuff out there. So I've got a bunch of questions to ask you, and I just kind of want to maybe just go through some, I won't say rapid fire, but just kind of like a bit of a hodgepodge of questions, just kind of inspired by some of your recent social media posts. And I'm really curious to get your take on a few different topics, like around mast cell activation syndrome and your approach to mold illness and heavy metals and whatnot. So I'm hoping we can plug through a lot of topics here. Probably take about 4 interviews to get through all of it, but we'll just do the best we can if that sounds okay to you as a format.
Absolutely. Let's do
Okay.
it.
Okay, great. So just before we get officially started, just as per usual, nothing that's said during the podcast should be construed as medical advice. This is for informational purposes only. If you need any medical advice, please talk to your healthcare provider to get that advice. So one of the things I was happy to see you post about, because it's one of my great loves in medicine, is ozone therapy. You had a
Mm.
couple of posts actually within the last little while, one about ozone therapy for neurodegenerative conditions and also for long COVID fatigue.
Mm.
And I try to stay abreast of the research. I teach a annual ozone therapy certification course for clinicians.
Uh-huh.
So I do a annual research review every year. So I try to stay really abreast of the literature. So anyways, I'd love to hear about your clinical experience using ozone for neurodegenerative conditions and long COVID fatigue, and anything else you want to say about ozone would be lovely, please.
Yeah, yeah, great. So we use 10 pass technique here in our office. We've been using ozone for, gosh, 7 or 8 years or so. And, ozone is what I often share with patients is it doesn't discriminate against infections. It'll treat viral, bacterial, fungal infections or colonizations. And, plus it has the added benefit of immune system modulation. um, really love that for some of our patients. It seems to work really well. We've been using it with patients that have long COVID symptoms, and that's obviously one of these challenging condition to treat right now, and we're still not sure the underlying pathophysiology, but ozone seems to be helping folks turn a corner. um, the neurodegenerative post, I don't recall specifically if it was a study. We've definitely used it with folks that have conditions like MS and Parkinson's, and again, the same mechanism of immune system modulation, dealing with underlying pathogenic burden. Those There seems to be some benefit there. I don't, probably like other therapies we use, sometimes we're not quite sure everything that's going on or what's even contributed to someone's illness. I had that conversation with someone yesterday about long COVID, right? Where there's so much great research now that's being done around cause of long COVID and what it looks like, and um, but the treatments haven't really caught up with sort of what we know about it. They're really, there's not a whole lot to offer, especially in the conventional world. So um, being able to use a therapy like ozone is great for our patients. We don't want to, it's like difficult to say, well, let's just wait another 6 months or 12 months or 18 months until we get the magic drug. But let's if we understand the underlying physiology or pathophysiology that's occurred, then why don't we employ therapies that are going to help to correct that? So it's ozone's been you know just one of the great therapies in my practice for a number of years, and really fortunate to have trained with some great ozone physicians nearby, and glad we have that tool.
It's great. Yeah, I oftentimes will describe it to folks as saying, like, if you had a wish list of everything you want a therapy to do, like, anti-inflammatory, antioxidant enhancing, tissue healing, mitochondrial supporting, antimicrobial, it's like ozone does it all and then some. It's
Yeah.
just it's the best. In
Yeah,
terms of,
I think also with our folks, or, see a lot of patients that are very sensitive to medications, right?
Mhm,
And so what's great about ozone is you're not introducing a drug or a foreign substance in their
mhm,
body, and
true.
and so people tend to tolerate it really well.
Mhm,
And especially our, like a mast cell type patients and really reactive patients. So
yeah.
another benefit is that it can be used in a lot of, in a wide patient population.
Hmm. Absolutely. Yeah. I find of all the IV therapies that we use in our clinic, I'd say that ozone is probably tied for first place of like least likely to cause adverse reactions, even in the super, super sensitive folks. So it's lovely. It's a good selling
Yeah,
feature. Um,
yeah.
in terms of your experience with ozone, not to linger too long on that topic, but in terms of, say, using ozone therapy in general with folks dealing with complex chronic illness, do you like, so what percentage of the time would you say that it's like more of a background supportive therapy that like helps to move them in the right direction faster, maybe not like rocketing to the finish line, but like it's definitely a synergistic agent that makes everything work better, versus what percentage of the time would you say that it's, it's a huge accelerator pedal that makes them feel way better faster? And then we'll just throw into the mix, since we're on a roll here, what percentage of the time would you say it just doesn't really seem to make much of a difference? Just ballpark, give or take.
Yeah, it's a good question. I mean, I think for, of course, a lot of our patients, they're doing multiple things, right? They're on supplements or
Yeah.
herbs or LDN and a variety of other therapies. And so, it's difficult to isolate it as it's the only modality being used. But, I would definitely, it's the vast majority of patients that we've done ozone with have benefited from it. I'd start there and say, what percentage of improvement have they had? Um, you know, and again, we use 10 pass technique, and people typically do it once a week. And remember, years ago, someone it seemed to see this pattern of around, after their someone's sixth or seventh treatment, they just really turned a corner for whatever reason. There was just,
Mhm.
it took, they got to that point, and all those benefits you just described seem to, come together and improve patients' symptoms. So I would say, 90% of the folks that we've ever used ozone with have benefited in some way, shape, or form. Um, what percentage and, how much have they improved with that? It could be anywhere from, say 50% to, 80, 90%. I have patients that are still in my practice, or I might see now and again for basic maintenance stuff. And they'll say, oh yeah, when we did ozone 3 or 4 years ago, that really made the biggest difference in my, and so, probably like yourself, medicine is, we learn from our patients, right? And medicine's very humbling, and just getting that feedback from our patients really helps inform us and how we move forward and help other patients. Um, yeah, and as far as a synergy is concerned, I remember, years ago hearing or reading somewhere that, if we had patients on antibiotics for, say, Lyme disease, there was some synergism that happens between ozone and being on antibiotics at the same time. And I really like that. I used to share that with patients often. It's going to make all these other therapies that we do be that much more effective. Um, so, great adjunct therapy in the totality of everything that we use. It just seems to have this big impact. And, I think one of your questions was what percentage maybe hasn't benefited from it. I'd say it's less than 10%, right?
Mhm.
I mean, if so you have a therapy that is, 90%, or it's going to work in 90% of your population, it's pretty remarkable.
It's true. Yeah. It's why ozone's on my top
Yeah.
three list, and I don't think it'll ever get bumped. And I
Yeah.
appreciate you bringing up, just and kind of alluding to the fact that for some folks, and I'd say majority of folks in my experience, like you usually it's around like maybe the 4 to 6 to 8 treatment mark that you start seeing the
Yeah.
change. Like I always try to do my best to explain to patients ahead of time, like, we're probably not going to see, like, you might see a change after the first or second treatment. If it happens, it's not a placebo. It does happen.
Yeah.
However,
Yeah.
it's, you want to make sure you give it enough time. It needs to kind of build up in the system, so to speak, or the impacts need to build up. And I find
That's right.
that's been my experience too. And I'd say similar stats in my practice. Like I'd say it probably has about a 90% like helpfulness rate to one extent or another. So glad to hear you're seeing the same kind of stats. Um,
Yeah. Yeah.
one of the other things that I wanted to, I was very excited to ask you about because I've asked a number of my other guests about just kind of any novel or like lesser known tools for helping with mast cell activation syndrome, because I feel like identifying
Mm.
that and addressing it is so important for so many cases, and yet I feel like the number of tools we have in our tool bag are just it's a relatively modest number. So I was excited when I saw your
Yeah.
post about, I'm not sure if I'm pronouncing it correctly, but was it cyproheptadine? And
Yeah.
you had that listed as an antihistamine, and it's been on my list to look into it. It's like, hey, I'm talking to Todd today, so I'll just ask him about it.
Yeah.
So could
Yeah.
you speak to that? Have you used it in practice? What's the story with that?
Yeah, so right, it's not one of the more common antihistamines that you hear, or that commonly comes up as a therapy for MCAS. And I first learned of cyproheptadine from Dr. Theo Herides,
Hmm.
who's one of our leading mast cell researchers and at Tufts University. And I heard him speak about it years ago at a conference, and there's some unique benefits. For example, it can help with migraine prophylaxis, right? So if you have a mast cell patient that maybe has a propensity towards migraines, I'll try it in those patients. Um, I think like a lot of mast cell therapies and kind of channeling Dr. Larry Afrin, who's another one of our leading mast cell experts in the world. I've learned a lot from him over the years, and he would say with patients, you really just have to try, and try again. There's no one therapy that's going to be the magic bullet for all. I mean, I think on the kind of work that you and I do is to get at those underlying root issues that are causing the mast cell dysfunction. And mast cells being a part of our immune system get triggered by various toxicants and pathogens. And I think there's a cohort of physicians out there that will focus on just the mast cell component of it, but that's almost like treating the smoke and not treating the fire. Getting Just correcting the whatever has contributed to that immune dysfunction in the first place really helps with the outcomes. I like to stabilize mast cells and put people on mast cell supportive therapies while we're working on those underlying causes. But you know, uh, I don't think it's the end all be all. I think it's a part of or secondary to. So um, yeah, there's a lot of therapies out there. I think things like I use LDN in a lot of my patients, and LDN
Hmm.
does have some benefits with mast cell. Um, then of course you have your H1s and H2s, Claritins and Allegra, Zyrtex and Pepsids. Um, but then medications like cromolyn or ketotifen, those are great medications. I heard something the other day that ketotifen is I think has three mechanisms. It's an antihistamine, it's a mast cell stabilizer, and it's a leukotriene inhibitor. For all those listeners out there.
Trifecta, triple whammy. Yeah.
But basically, it's a can be a very effective medication. Now,
Mhm.
like everything, doesn't work for everyone. Someone has gut issues and leaky gut inflammation. They're gonna be triggering mast cells all the time. A couple years ago, I'd always wondered about that connection between things like leaky gut or SIBO, leaky gut, mast cell activation, this triad that can,
Mhm.
and is it, what's chicken, what's egg? And we know that when there is bacterial overgrowth in the small intestine, that mast cells migrate to that site, they'll release their contents, which create inflammation and then lead to leaky gut. When you have gut inflammation, everything that's in your intestine ends up triggering this systemic immune response.
Mhm.
So all of a sudden you have this vicious cycle now where the immune system's being activated. And so when we keep, I always say it's like the annoying, 4-year-old that keeps asking, but why, but why, but why? When you keep digging deeper and look for that why and address that, you're the trickle down or the side benefits are going to be immune cell normalization.
Mhm. And just on the topic, of kind of a side question here with the triangle. So if there's MCAS and leaky gut and so was it dysbiosis that was the other?
Yeah, yeah,
Yeah.
yeah.
And so I'm
SIBO,
just right, SIBO or anyway, some type
any,
of
yeah,
dysbiosis, but well, SIBO sounds
yeah,
good.
yeah.
So have you had like are there cases that you've seen where someone's like trying to stabilize mast cells or working with histamine receptor blockers. Like they're trying to cover the histamine bases quite well. They're going after the SIBO with antimicrobials, but the patient's only made so much progress. But then bringing in the gut healing implements, whether it's glutamine or butyric acid or whatever it happens to be, demulcents, whatever it is. Have you seen that gut healing kind of break that cycle, that kind of triad cycle, or like how often have you found that as a um, uh, sort of a, I won't quite say single variable because there might be more than one component to it, but
Yeah.
how often do you found that sort of treatment angle to be really pivotal to kind of crack an otherwise difficult case?
Yeah, pivotal is the operative word there. I think it really can be for people. Given that 80% of our immune system is right there around the gut. Clearly, gut health has a big impact on how our immune system is going to react. And so for some folks, I sometimes say it's like having the tacks in the foot, right? And if the maybe their gut inflammation is a bigger nail in the foot, and removing that or correcting that, it could have a major impact. For other people, they might have a systemic infection, right? One of our tick-borne infections or viral infections that therapies need to be directed at that. Um, Everyone's unique, right? And everyone kind of comes in the door with their own set of symptoms, and you could have 10 people with all similar diagnoses, but I guess what comes to mind is, what percentage is each one contributing to their symptoms or their adverse health. Same thing for having 10 physicians in one room with one patient. You might have 10 different approaches,
Oh yeah.
and we, as I say, it's practice, and you're helping the patient navigate. I think what's important is just is being able to look at the patient each time with kind of fresh eyes, and make sure that we're getting everything that they're presenting to us, and making sure that we're addressing each one of those tacks in the foot to help move them forward. And yeah, sometimes as you're banging your head against the wall and trying to help, as what we call complex chronic illness, is it's like,
Mm.
how did we sign up for this, right? And it's so rewarding when you can help patients, and there's not many physicians out there that have chosen this path um, to go down with their patients, but it is so rewarding when you can make a big difference. I think it's conventional medicine will always struggle to be able to help complex chronic illness, because the model isn't set up to support that, whether it's the short office visits because that's dictated by insurance reimbursement, to the drugs that are all directed at treating the symptom. um you know it's always going to take physicians that are able to spend adequate time with our patients to be able to use cutting edge diagnostics and progressive thinking. Kind of makes me think back to anytime you meet someone and you tell them that you're a naturopathic doctor, or experience I've had is, a lot of times people say, well, is that like a homeopath? And say, well, yeah, I mean, we use homeopathy as a modality, but I think what's unique about our profession is we're um, the philosophy is different, right? The approach is different. The goal is to look and
Mm.
address the underlying root issues, which is quite opposite of what conventional medicine does. Sometimes I'll joke with patients. It's like, it could be quite easy to practice the conventional model, right? If someone's in pain, you give them a pain med. If someone is depression, you give them a depression med. It sounds funny when you say it. It sounds so simple and so easy. But if someone's in pain because their immune system is dysregulated, and they've got some underlying pathogen that's driving an immune mediated cytokine response, well, that's a different story. Yeah, you might palliate the pain while you're but you still need to get at that underlying root issue. Otherwise, it's not a sustainable approach to just be on pain medication or whatever. I call that the disease drug model, right? It's like you get the label, and then here's the drug that's been associated with that label. And you know, you're probably seeing this in your practice as well, and I've heard other physicians that have been doing what we do for much longer say that the patients we're seeing now are much sicker than they were, 10 years ago. And is that environmental influence? Is it, dietary? Is it all the above? Other issues. But the people we're just seeing more and more chronic illness, and I'd say in younger populations too.
Yeah.
Used to be the person that's in their 30s, 40s, 50s, and now we're seeing people in their 20s and teens, with complex illness. So we got our we have our work cut out for us, and it's a real honor to be practicing the type of medicine that we do.
Yeah, I concur, and I think that especially the group that we're both part of, the ICI, the International Society for Environmentally Acquired Illness, like I think that it's so important that clinicians like us and others in that group and others who aren't in that group, hopefully a growing number, are just mindful of those environmental impacts. Whether it's
Yeah,
mold toxicity or chemicals, or I mean maybe talking about like Wi-Fi or other types of electromagnetic radiation, various things like. Think it's super important, because my hunch is that we're sicker because of just having been inundated with chemicals for tandem generations now for a while. I think that that's my pet theory in terms of what's going on. But yeah, I think it's very important to be aware of, and man, something's got to be done about it, because we're
yeah,
so far down in the process. Like, okay, so patient, you're really sick, but like, man, there's a lot of steps that got you to this point, and like, man, oh man, there needs to be more work done on more upstream so folks don't get sick in the first place. But that's kind of outside of my
yeah,
realm. I don't know how to fix that. That's more on the political level or societal structure
yeah,
level, and that's where my head starts to spin a bit more.
yeah. I heard a quote someone being interviewed the other day, an immunologist, say something to the effect of, look for it, pull it up so I'm accurate in what he said, but I'll paraphrase here. He said, our our immune system, or maybe our immune reactivity, is a result of everything our immune system has seen in our entire lives.
Hmm.
And so, and this is sort of it was a long COVID type of interview, and I thought about that, and you can appreciate this knowing immunology, but for basically our immune systems do sample everything that we come into contact with, right? So an infant, a newborn, is going to have hasn't seen as many pathogens or toxicants or whatever it's in its lifetime, but as time goes on, and our macrophages and the cells that sample everything that we're exposed to, it creates a memory. There's an imprint that occurs. And so in our fourth decades and fifth decades and sixth there's a whole lot that our immune system, this memory, if you will, and I'm not specifically referring to antibodies, but more of this reactivity and ability to respond. It's based on everything that our immune system has been exposed to in our lifetimes. And so why does someone that gets it back to the long COVID conversation, but why does someone end up with these long-term symptoms, and then other people not so much? And he was talking about how the virus can come and go, almost like what he called a hit and run. And and you could even say the same thing about Epstein-Barr, right? That maybe triggers a fire. He says starts the tinder, and then the virus is gone, but the fire persists, and that's that immune system response. So at the end of the day, I think so much of what we deal with, has to do with immune dysregulation. And immune systems are, I think, the most complicated system in our body, by far. And um, some of our efforts to help patients get better, I think, need to be directed at immune system dysregulation.
Yeah, I couldn't agree more. And actually, on that note, I know you mentioned using LDN, and for folks
Yeah.
listening, low dose naltrexone. Are there like what would say be some of your other, top 3 to 5 immunomodulators to work
Mm.
with in practice, if you don't mind sharing?
Yeah, yeah. I mean, yeah, LDN is kind of like you said with ozone. It's is one of those top threes in my toolbox that
Mhm.
um, I often say it's, if I that one's often reserved for the majority of my patients. Ozone, of course, being an immune modulating
Mhm.
therapy as well.
Yeah.
I love, some turmeric is a favorite of mine. Things like transfer factors I use a lot of in my practice.
Mhm.
Um, and then, ultimately things that glutathione kind of falls into that realm as well, but also antioxidant detoxifying therapy. So not just immune modulation because it can, but also those other aspects of it.
Mhm.
Yeah, those are some of my favorites.
Great.
And I use LDI in my practice as well.
Oh, you
So
do. Oh, great.
LDI, LDA,
Yeah, great.
and LDN, all the acronyms.
There you go. Yeah. Half the time I recommend LDI to a patient, like, so the LDN, I'm like, no, no, it's the other LD one.
Right.
Just out of curiosity, I didn't know you were an LDI guy, so it's always nice to meet
Hmm.
another fellow LDI
Yeah.
practitioner.
Yep.
What do you mind just sharing, like, which of all the myriad formulas that are available,
Mm-hmm.
what are the antigens that you find tend to be the most commonly helpful for your patients?
Yeah. And when I say think of LDI, I think of Dr. Vincent's
Of course.
antigens, and
Yeah.
LDA's more of Dr. Schrader's and
Yes.
the foods inhalants, etc.
Yeah. Yes.
And started with those, and then soon after, began using Dr. Vincent's antigens,
Hmm.
and primarily got into it for tick-borne infections. And so I've used the Lyme mix
Hmm.
probably more than any other in my practice
Hmm.
over the years. I'll use the yeast mix, and some of the viral ones now too, more so.
Hmm.
Um, and those are probably the more common ones that I use. I've used strep and some other mixes as well, but I'd say the tick-borne mix, the yeast candida mix, and the antiviral or the viral antigens.
Right.
Yeah,
Yeah,
yeah.
that's same with me. And I think if we asked Ty, he'd probably say the same thing. Those seem to be the workhorses of the LDI world.
Yeah,
And
yeah, yeah. Yeah, with mold, I've heard him say before. I mean, if someone has mold in their body, they need to be out of a moldy environment. It's a
yeah.
toxicant. You need to detoxify them. Could you help reduce their immune reactivity?
Mhm.
Sure, but ultimately, I think we're dealing with a toxicant here that needs to be removed from the body, and yeah, hopefully we'll circle back about mold down later on. So we'll
Sure.
put a
Well,
yeah.
we can circle to it now. What
Okay,
uh
okay.
what would you like to
Well,
share about mold?
yeah, it just got me thinking when we were talking about, when I went off on my soapbox there about how, or just how do we truly heal, and treating underlying root
Mhm.
causes. And um, my mindset or paradigm has shifted a little bit, and recently with even treating mold illness, where I think historically we go, okay, there's mold, and we'll detoxify with things like binders and glutathione. And I also use antifungals in my practice, and and clearly the first step is always to remove the patient from the moldy exposure, make sure they're not being exposed to mold.
Mhm.
Um, but we recently started sending blood to a lab in Germany, and that does it looks at various things like mitochondrial issues and or mitochondrial membrane dysfunction, and DNA adducts, and sort of a looking at an intracellular level, what's happening there. And so you might, or historically, I think I would have, you treat someone for mold and you read tests, and eventually their tests are negative, and you go, great, we've healed you from mold. But um, when you take it one step further, and look at what's happened on a cellular level, whether it's a cell membrane issue, or organelle mitochondrial issue. You go, well, this is the damage. I call it the collateral damage that's occurred. How do we truly heal and repair, you know, this damage that's also occurred, so that we're, maybe someone's asymptomatic at this point, but how do we prevent things like, Parkinson's and MS and maybe other conditions down the road that may develop because of this damage that's occurred? We know with DNA adducts, for example, that toxicants, including mold, can form DNA adducts. Well, those can lead to cancers. And how do we truly help someone heal? And I don't, at least in my practice, I think that hasn't always been, at the forefront. I think most people too are concerned when they're symptomatic, and once they're asymptomatic, they go, they're better. But on a cellular level, it's sort of hard to assess. So now, that shifted a little bit. We do a lot of phosphatidylcholine intravenously,
Hmm.
and that is really helps with cell membrane repair, and that's been a big part of my practice with my mold patients.
I'd like to ask you a couple of follow-up questions on that.
Yeah,
And maybe just phosphatidylcholine first, if you don't mind.
yeah,
So I've played with IV phosphatidylcholine largely under the influence of Dr. Paul Anderson, who talks about the benefits of that quite a lot, and sort of like these cellular repair protocols. And I know I think one of my susceptibilities as a clinician is I'm impatient for results. So
yeah,
over time I've learned like, yeah, I'm gonna wait till like we've done at least half a dozen ozone IVs before I make a judgment call. But for a lot of other ones, I'm kind of like,
yeah,
like if I'm not seeing a change within like 2, 3, 4 treatments, like tend to be pretty quick to throw in the towel before
yeah,
moving on to something else. With the IV phosphatidylcholine, well, I've seen some like amazing results in terms of patients with like notable liver dysfunction, like cirrhosis or like other types of liver disease.
yeah,
I've been so far like fairly underwhelmed with IV phosphatidylcholine with treating bringing it into the complex chronic illness world. But I'm my rubber arm is ready to be twisted to try it again. So would you mind just
yeah,
sharing like is like how many treatments would you typically need to run to see a change? What kind of changes have you been seeing? If you don't mind just sharing on that, could you please sell me on trying the
yeah, yeah,
phosphatidylcholine IVs again, please, for my patient's sake, because I don't want to be missing something important for them.
yeah, yeah. And I don't, clearly doesn't work for everyone.
Sure.
I've learned about PC peripherally from other physicians and that have had great success. And there's some kind of leading researchers out there that have Patricia Kane was really in, obviously, all her lipid
Bruce.
research, and her husband, her late husband Ed Kane. And um, so what the protocol isn't just PC, of course. We often use other glutathiones involved, and methylation support, and some nutrient support now, that especially since we're using this lab where we can see intracellular, maybe nutrient deficiencies like zinc for DNA repair. um, and there, as far as the number of treatments are concerned, there was some researchers maybe a half dozen years ago that were looking. They were looking at cell membranes under electronic microscope, and they had, you know, people that you could see the damage that had occurred, and then they administered a number of a certain dose of phosphatidylcholine over a period of time, and then reassess the cell membranes. And they came up with an equation that was some around, I think it's one gram of phosphatidylcholine per kilogram of body weight, and that can equate to, it ends up being uh, whatever we end up administering. It might be 20 IVs, right, or
Yeah,
more, depending
that's a
on
lot.
someone's size. So
Yeah.
it's a lot. And I think also historically we were kind of basing that off of just information we knew, and we hoped that it was working on the cellular level. And now I'm excited that we're kind of measuring. I tell my patients it's like we're quantifying what's going on on a cellular level, which we've really never been able to do. And so I'm looking forward to follow up samples that we'll retest and see what's changed after those treatments.
Hmm.
Um, the group that was doing the microscopic work, I don't know if that lab ever became commercially available. I think there was talk of it years ago, but to my knowledge, it's not available for us or public use. It was
Hmm.
research, and yeah, you might know about it. Uh, yeah.
Oh,
So anyhow, this is
oh,
the
sorry.
one
Which? No, no, sorry. I'm
oh
just nodding because I'm hearing you, but no,
oh,
I
okay,
don't
got it.
know. I don't know what it is.
Sure, sure. Yeah, there were researchers in the UK that were doing that work, and I don't think that lab ever came to be, publicly available. So there's very few ways to assess what's happening on a cellular level, and I guess this way, I'm excited, to see what comes from doing those protocols with patients and then repeating their blood work to see,
Hmm.
what's improved on a cellular level.
Yeah. And just so I'm not reading incorrectly here, so is
Yep.
it sometimes taking like around 20 treatments with IV phosphatidylcholine along with the glutathione and other adjuncts to see
Hmm.
clinical changes? Or like what would be a, if somebody's going to come in weekly for IV phosphatidylcholine with the appropriate adjuncts, like do they need 4 treatments to see a change on average, 10? Like I'm just curious.
Yeah, it's a good question, and I tend not to necessarily monitor the efficacy of something based on their symptom improvement.
Mm.
If someone is out of their moldy environment and we know that they were maybe in it for a period of time, or they look back and they go, gosh, even the house before I was in had a lot of mold, and
Mhm.
it just successive exposures to mycotoxins, and maybe they're presenting with a neurodegenerative condition. Then I what I often say with chasing symptoms is sometimes like the dog chasing his tail. It'll drive the patient mad. It'll drive the doctor mad.
Mhm.
But part of it has, in this case, it'd be looking at that the objective lab evidence. Are we
Okay.
seeing improvements there? And
Okay.
clearly, people will report. I get a lot about the mitochondria, and getting someone's mitochondria back up and working well, and they'll start to say things like, yeah, I noticed that I can, my energy is better, and I'm getting fewer headaches, and maybe my neuropathy is less severe. It used to be a
Mhm.
whatever 4 or 5 out of 10, and now it's down to like 1 or 2 out of 10. So
Right.
you'll see these subtle changes with time, and I try to help my patients keep the big, kind of the big picture in mind, so that we're playing the long game and know that, in this case, maybe we're also going to prevent illness down the road, um, which is rewarding.
Yeah, we got to take care of those mitochondria because they seem to be implicated in every chronic illness out there. So, yep, I'm taking good care of mine as best I can every day.
Yeah.
Super important.
Yeah.
If you don't mind, would you mind sharing with us what the lab is in Germany that you're using?
Yeah, it's called IGL Labor. First learned about it from a colleague that spoke at an ICI conference, I guess last year,
Hmm.
last spring, and
Hmm.
it's taken a while to get. It's a little challenging to get blood over to Germany, but we've figured it out now, and the testing so far has been insightful.
Okay, great. And it's primarily like nutrients and like you said, I think you said they're assessing mitochondrial function to some extent.
Yeah, they do, cardiolipin, mitochondrial membrane dysfunction. There's multiple markers in each little
Cool.
panel.
Yeah,
There's DNA adducts that they'll measure. They measure SOD, superoxide dismutase activity.
great.
They also have a toxicant portion of the panel where they use a methodology called IEC, which is intracellular electrical capacity, kind of a unique way, at least a way I'm not familiar with here in the United States, but it's a unique way of measuring toxicant burden within lymphocytes, so
Hmm.
in our white blood cells,
Hmm.
and that's really great to see the toxic burden. Their standard panel, I think, looks at 24 different toxicants, but they have other panels that you can run. There's a pesticide panel or insecticide one, a silicone panel if you're concerned about someone reacting to silicone with implants. There's a variety. It's very cutting edge and very German. Um, yeah.
There's some great German labs, and I'm part German, so I take a little bit of the credit for
All
my
right, good.
race.
Yes.
So, um,
Right, good.
is it measuring the? I'm assuming it's measuring the mitochondrial function in the white blood cells then, since it's a blood sample, or
Yeah, that's a good question. The report comes back and it's all in German, or it's it's a little difficult to decipher. I don't know if they're using white cells or red cells for mitochondrial membrane function. I'd have to check.
Mhm. Okay.
Yeah.
Yeah, well, I'm definitely going to look into it. Yeah, there's been a
Yeah,
couple.
yeah.
Was the lab from the UK, was that the Sarah Myhill lab?
I don't know if it was a part of Dr. Myhill's lab or
Okay.
not. I know it was someone I believe that Dr. Kane was working with,
Oh, okay.
um,
Okay.
so from here in the U.S.
Okay.
So I don't know if it was part of Dr. Myhill's group or not.
Great. I thought
Yeah.
that test panel looked really cool. Like, it's really interesting, but I guess there was some mixed reviews about the research evidence around it, and I don't know. And I guess you can't have it done outside of the UK, so I was just curious if that's what you were referring
Uh yeah. It was microscopic work and
to. Okay.
around cell membranes and then
Oh,
repair following a certain number of phosphatidylcholine
right.
IVs.
Okay. Must have been something different. Okay.
Yeah.
Um, I know we're getting close to our deadline here to wrap things up. I've got a couple of I have well, litany of questions here I could ask you, but
All
are
right.
there any other topics that you particularly like to talk about before we start winding down, or
Ooh.
otherwise I can throw something out there.
I'll defer to you. You've got
Okay.
great questions
Oh,
and
thank you.
and know what your audience likes, so I'll defer to you.
Okay. All right. Well, sounds great. Well, let's see here. Actually, we've covered quite a bit. So let's see here. I guess. Um, Well, okay. So I guess maybe outside of the IGL Labor test that you just talked
Yeah.
about, could you share with us what your top 1 to 3 favorite functional lab tests are?
Hmm. Good question. Um, I have I would say a renewed interest in Cyrex labs. Recently, some of the immune, profiles that they have a lymphocyte map test and
Hmm.
an autoimmune antibody panel, and those are great as far as functional is concerned. Of course, I do my usual tick-borne labs and mold-related labs.
Do you mind
Um,
sharing which labs? Like, this isn't a CME,
oh, yeah, for sure, we can say
available.
anything.
So yeah.
Well, I primarily use IGeneX for tick-borne
Hmm.
infections, and I usually I prefer to do a full panel the first time with the TBD4 panel, which is fairly comprehensive. For viruses, I've been using Infecto Labs T cell testing,
Hmm.
Infecto Labs in Wisconsin,
Oh, okay.
and
And sorry, is that
they
so? Oh, sorry to interrupt. Is that
no.
like through ELISpot testing or some other type of T cell
Yeah,
test?
they're T cell tests. So Infecto started in Germany as well, and
Mhm.
they have a North American lab now, and I guess for a few years,
Mhm.
um, and they call it. They're looking at 10, interleukin 2 and um, oh, what is their other cytokine? It's their T cell profiles that they'll run, and they do, what's great about the T cell test, of course, is whether or not I think it helps people determine if it's an active infection or not,
Yeah,
right? And
yeah, for
with
sure.
viruses in particular, antibody testing's never been that reliable. And a lot of people that, will say that they have EBV, and of course they just have high IgG titers, and
Mhm.
we used to kind of default and say, well, maybe, yeah, that's a reactivated infection that's
Mhm.
raised up these IgG titers, but it's
Right.
it's really still a little gray and ambiguous. And but the T cell testing is really, at least in my experience, it's insightful. And if I see
Great.
a positive T cell test, I'm going to think, it's a interferon gamma interleukin 2 are the two that they look at with at Infecto Lab. Anyhow, if I see a positive T cell test, I know it's going to be that's an active infection. It's something that's going to get my attention and,
Hmm.
you know, I
Great.
want to treat. With mold testing, I've used urine mycotoxin testing over the years. About 3 years ago, I was introduced to my Myco Labs, which is a mycotoxin antibody test.
Hmm.
And you know, I often share with patients, and I'll share it today, that every test has a limitation, right? Whatever you're looking at, you could, whether it's heavy metals I trained with Walter Crinion in environmental medicine, and Dr. Crinion would say, the 6 hour provoked urine test is what it's telling us. It's just reflecting what the body's willing to let go of in that period of time. It doesn't. We think it's telling us total body burden, but that's there's limitations there. There's variables that come into play. You could say the same thing about a urine mycotoxin test. Mycotoxin antibody testing has been I've appreciated it the last few years with my patients, but I think it's missed some patients as well. But again, it's just telling us if there's an immune response to mycotoxins. Someone can still excrete mycotoxins in their urine, which in theory would reflect a toxic burden. But I think urine testing has a limitation, right? So it's like if I went over to someone's house that had mold and spent 2 hours there and then collected my urine the next morning, I'm going to see mycotoxins. That doesn't necessarily mean that I have mold illness or mold toxicity. It means that's the normal route of elimination.
Hmm.
So every test has its limitation. I think that's where we come in as clinicians, is to interpret the results, see if the the information, the objective evidence is consistent with the subjective patient complaints or
Yeah.
symptoms, and then we form that interpretation and come up with a strategy to help the patient move forward with their health.
That's the game plan every day.
Yeah,
Yeah.
yeah.
Well,
Yeah, it's I sometimes think about, what are physicians? What do we do? Our job is to we try to obtain and retain a lot of information to be able to you know connect dots, make associations. We see patients, everyone's individual, right? And they've
of
come with
course.
their own set of contributions, just like the immune system and everything it's seen in a lifetime.
Hmm.
And our job is to put all that together and learn from our patients, and that experience, carries on to the next patient we see, because we've made associations. And some people, need limbic system retraining, right? They've had trauma, or they're stuck in a sympathetic dominant state, and sure, they test positive for Lyme or mold or whatever, but maybe the piece of their healing pie, the greater percentage is that they need to do some sort of limbic retraining. And so, yeah, it's medicine's humbling, and I
For
love the
sure.
work that we do. I couldn't imagine doing it any other way. I think it just it would be unfulfilling to practice that disease drug model that I referred to earlier.
Well, you're definitely in the right field because you're obviously really passionate about what you do, as am I, and I'm thankful we have
Yeah,
groups like ICI and iLads and others where
yeah,
yeah, it just draws a lot of really passionate docs, and we need each other to lean on and learn from. So
yeah,
glad to be part of those
yeah,
groups.
yeah.
Just where we're a couple minutes over our time here, so thanks for
All
the
right.
extra bit of time, and I really appreciate you chatting with
Yeah.
me today. Just before we part ways, would you mind just sharing with folks how they can get in touch with you if they like? Do you offer long distance consultation services? Do you have any online offerings, social media pages? I already spilled the beans. You have an Instagram page, which I'll
Yeah,
post in the
yeah.
show notes. But yeah, could you speak to any other offerings that you have?
Sure. Yeah. Well, I like to write. I like to put out information. I haven't been writing a whole lot lately because I've been working on some other projects. But my website, I've posted some articles on. It's drtoddmaderis.com. And my Instagram, I believe, is Dr. Todd Maderis, but if you search, you'll find it. And my Twitter might be Dr. Todd. I am not 100% certain there, but if you post it in the notes,
I will definitely do that.
yeah. But we do like to post a lot of try to keep up with the research and post that on Instagram. It's get a lot of positive feedback that people appreciate it, and it helps me too. You know, we're always learning. There's always something new to learn, and it keeps me inspired to keep finding new information to share. So
It's good. Well, we definitely appreciate it, and yeah, so
and
much to
I
learn. So,
yeah I don't do long distance consults. I only see patients in California.
okay,
So if they're located in California, then I do see them. But people enjoy coming out to beautiful Northern California sometimes, and so we have we'll see people here in person or remotely if they're in California.
great. Okay,
Yeah,
great. Well, I'll put all the contact information in the show notes, and thank you so much again for taking the time
yeah.
with me today. Really appreciated the chat.
Thank you for having me.
Yeah, my pleasure. Well, thanks everyone for listening to another episode of the Overcoming Chronic Illness podcast. Hope that you had, I hope that it was a fulfilling learning experience for you, and please stay tuned for the next episode.